I was appointed into post in July 2016, although I resumed in early January 2017. So I've been in post for about 2.5 years, getting to 3 years now. Prior to coming to Nigeria, I've been working in the UK for about 20 years. My last job was as a senior hospital consultant in Cambridge, Cambridge University Hospitals. My specialty is infectious diseases and microbiology. Predominantly what we do relate mostly to infections, particularly community infections such as HIV, tuberculosis, as well as admitting patients and dealing with issues that have to do with antimicrobials, including antiretrovirals. I was appointed partly because of the situation we had at the time I came into NACA. There were issues with our grants, particularly our Global Fund grants. There was also the feeling that NACA was drifting away from its original mandate, which is really to coordinate the HIV response across the country. Since then, we've made tremendous progress. You're probably aware of the HIV survey we've done, which has enabled us to know the true burden of HIV in the country. We've been able to establish that the size of the epidemic is about half of what we initially thought, which is good news because it means we can then identify resources and put in place money so that we can get on top of the HIV epidemic. We've also restored the relationship we've had with our external donors. I think sustainability, we're gradually moving towards sustainability. The federal government has committed to putting about 50,000 persons every year on treatment from 2019 from its own pocket, in addition to fully accommodating the patients that we have currently in Taraba and Abia on our HIV programs. In addition to that, we are interfacing in terms of trying to work with the National Health Insurance Scheme, as well as state health contributory schemes, as well as state governments to improve funding, because I think a lot of the issues we have with the HIV response in the country has to do with domestic resources. And what we've been doing together with our partners, particularly the US government and Global Fund, is we have this OVC program, which is called Orphans and Vulnerable Children Program. And essentially what it does is we provide funding to enable orphans and young children to remain in school, to be able to access a good education, and to be able to make something out of their lives. We also have women empowerment programs, as well as poverty alleviation programs under the federal government. I'm sure you've heard of the N-Power and the N-SHIP program. Essentially what we are trying to do is to provide information on what is available through government, so that our community, our HIV community, will have that information at hand and will be able to apply and benefit from it. We are also trying to look at creating a database that would enable us know what proportion of our HIV community that are currently considered to be sort of poor or very poor, that should satisfy the criteria for accessing these services. Overall, I believe that poverty is a major barrier to accessing treatment. If you don't have money, if you wake up in the morning and you don't have money, you will not be able to transport yourself to your nearest clinic to collect your drugs. You will not be able to. And even if you are taking medications, if you wake up in the morning and you don't have money to eat, drugs will be the last thing on your mind. You would want to look for food. So we understand those links, and we understand the importance of making sure that whatever we provide, the care we provide to our community is a holistic one, not just looking at the medical aspects, but also looking at the social and interventional aspects of our program. Since I've been here, we've done about 2 to 3 outreaches in the IDP camps, say in Abuja, where we have provided them with educational material. We provided them with food. We've also provided them with educational leaflets and advocacy material as it relates to HIV. We've also done HIV testing within these communities. And we continue to support all those that are vulnerable, particularly if they are vulnerable to exploitation or vulnerable to HIV exposure, because we've got to close the tap. It's not enough to just say we are putting people on treatment, we've also got to address the issue of prevention. And as they say, prevention is better than cure. It's much, much cheaper to prevent a case of HIV than to have to manage it for years on end. What we've been doing is mostly in the area of advocacy, particularly as it relates to law enforcement and also as it relates to health facilities, healthcare workers. Because sometimes the first stigma you tend to have really comes from the healthcare workers themselves. Yeah, as a member of the key population, you go for a HIV test. Right from the beginning, you are treated differently. That's not acceptable. So we've done a lot of work with our healthcare workers to try and reduce that. We've also done work with law enforcement, particularly the police. We now have a very good working relationship with community of police that tend to deal with these sort of issues. So when I came in, our data for people living with HIV was not very reliable. And I'm very pleased that we've been able to re-establish that data. We know now with a fair degree of certainty that we have about 1.9 million persons in Nigeria living with HIV. And we have just over 1 million persons on treatment for HIV. So which is good. But at the same time, we understand the challenges that comes with placing people on treatment. So for instance, I can tell you that we have a fair amount of leakage in terms of loss to follow up, people being placed on treatment and never coming back again for their repeat medications. And we're trying to look at the quality. We will be moving away from just a game of numbers to that of quality of care. Making sure that people continue to have access to medications that they can take. In terms of the challenges that people living with HIV are facing, it's very similar to some of the challenges we have even within our general society. Issues to do with poverty alleviation, issues to do with literacy levels, issues to do with employment, and even more importantly, stigma and discrimination. And here we've done a lot of work with our civil society partners, including the network of people living with HIV/AIDS. It was together with them that we were able to get through the anti-discrimination bill, and we now also have a Disability Act that's just come through. And don't forget, our clientele include people who are disabled, and it's important that we continue to make sure that they have access to services, especially if they are being stigmatized or discriminated. And there have been instances where we've had to take legal action. We have at the moment somebody who's we've just helped to win a court case because they were unfairly treated and they were dismissed from their work simply because they had HIV. Employers are now no longer allowed to do a HIV test simply for the sake of employment. The message we are trying to put out to the community is, before, if you discriminate against a person with HIV, you might get away with it. This time around, as government, we will support those that have been discriminated to seek their rights in the courts. Government is very much with people living with HIV. We will continue to support them. In terms of medications, we know we have a contract with them. Once we put you on drugs, it's like we're giving you a contract, we're signing a contract with you that we will look after you and make sure you have access to your medications. And NACA will continue to make sure that this is the case. We have a lot of facilities across the country that have opened medications. Antiretrovirals should no longer be an issue in terms of availability. They are also free. Anybody who charges you for a HIV medication, it's wrong, it's criminal. We provide those drugs for free and people should not be paying for it. In Nigeria, we continue to contribute a substantial number of babies being born with HIV in the world. The last time we checked, it was about 1 in 4 babies having HIV. That certainly is not an acceptable situation to government, and we continue to work with our partners to make sure that we reverse this situation. And it has to do really with trying to get pregnant women to access antenatal care. The issue that we've had is because the HIV programs are vertical programs. They are not integrated into maternal and child health. And over the last 1-2 years, we've been working with the Federal Ministry of Health to reverse this. We have the Saving 1 Million Lives program, which is a World Bank credit facility that now brings in HIV test kits, making them available for antenatal clinics. We are also adopting what we call a bundle approach, where pregnant women will be offered HIV as part of a bundle of care. That will include things such as testing for PCV, genotyping for sickle cell disease, etc. So that it's not just HIV you are trying to address, you're also trying to address all the other issues that have to do with pregnancy. And then finally, we understand that a lot of Nigerian women do not even go for formal antenatal care. Some go for traditional birth attendance, some go for delivery in churches, etc. And therefore, making sure that HIV test kits are available to outside the normal orthodox normal set of medical facilities. So for instance, making sure that traditional birth attendants have access to HIV test kits, pushing HIV self-test kits so that they are available to pregnant women, and pregnant women can be tested and be brought to facilities for treatment is really essential. So we are doing a lot of things, but I do believe that the PMTCT challenge will continue to be a challenge for some years to come as we try to integrate and improve our primary healthcare facilities across the country.